Welcome. I'm Dick Kozarek. I'm the Executive Director of the Digestive Disease Institute at Virginia Mason Medical Center in Seattle, Washington. I'm going to be synopsing an upcoming GIE original manuscript entitled Covered and Uncovered Metal Stents Provide Similar Relief of Biliary Obstruction During Neoadjuvant Therapy in Pancreatic Cancer, a randomized trial. This is a prospective multi-center study, 9 centers in Asia, Europe, Canada, and the United States, looking at covered versus uncovered wall flex stents placed in the setting of malignant obstructive jaundice in patients with pancreatic malignancy. What do we know about pancreatic cancer? Well, we know it's a miserable disease, that if you subtract patients with malignant neuroendocrine tumors, the 5-year survival of the overall group is 6%, and 10 years ago it was 6%, and 20 years ago it was 6%. We know that historically only 10 to 20% of people have been resectable for cure. And we know that in the 70% of patients who present with obstructive jaundice, preoperative stenting with at least a plastic stent doesn't improve surgical outcomes, and it does not improve survival outcomes. What's happening now in pancreatic cancer is an attempt to change the number of patients that are appropriately treated and that can undergo surgery, and to downstage them. As such, neoadjuvant therapy for 3 to 6 months is often given, and it is historically was initially used in borderline resectable patients to increase the number of people who can undergo surgery. And more commonly, in many centers, it's being used in everyone who has a planned pancreatic resection for the malignancy. The study was a randomized controlled trial of 119 patients with obstructive jaundice related to pancreatic malignancy. And they, again, were randomized into covered or uncovered wall flex self-expandable metal biliary stents. The primary endpoint was sustained biliary drainage, either to time of intended curative surgery, or to 1 year in patients who never went to surgery, and that could be because of disease progression while on chemotherapy, or because of patient infirmity. Secondary endpoints included technical success, adverse events, and we looked at both patient factors and stent-related factors that may have impacted our trial. Not surprisingly, both stents were equally successfully placed in 99% of the patients. Not surprisingly, there was dysfunction in a subset of the patients. In fact, about 73 or 74% of patients in both groups got to the primary endpoint, either to resective surgery or to 1 year. That means about a third of patients needed reintervention during that time frame. However, covered stents migrated. Uncovered stents had tissue ingrowth as a means of dysfunction. In fact, there was a 6.8% migration rate of the covered stents and a 16.7% rate of tissue and tumor ingrowth in the uncovered stents. There were comparable side effects related to stent placement, about 20 to 24%, not statistically significant between the two groups. the important thing to note that there was acute cholecystitis noted in 9.3% of our patients, and it didn't matter whether we put in a covered or an uncovered stent. A 4-centimeter stent was associated with significantly greater need for intervention than 6 and 8 centimeter stents. On univariate analysis, that was 2.9 times more likely to have to intervene, and the hazard ratio on multivariate analysis was 2.1. In contrast, patients with an intact gallbladder had a hazard ratio of 8.6 on univariate analysis and 6.4 on multivariate analysis. What's the takeaway from all of this? Number one, that both stents are effective, that they can be used not only to palliate patients, but they can be used to prevent recurrent obstructive jaundice in patients undergoing neoadjuvant therapy prior to planned curative surgery. Number two, the stents have different mechanism of dysfunction when they fail. Number three, that shorter stents, 4-centimeter stents, have significantly greater dysfunction than 6 or 8 centimeter stents, and it doesn't matter whether they're covered or uncovered. And finally, that patients with an intact gallbladder have a significant incidence of cholecystitis related to our manipulations. There are two other takeaways from this study. Number one, if you're uncertain of the diagnosis of malignancy, you may be dealing with autoimmune pancreatitis, autoimmune cholangitis, chronic pancreatitis, put in a covered self-expandable metal stent. It works as well as an uncovered stent. Number two, if, however, you have a diagnosis of pancreatic malignancy and you're doing neoadjuvant therapy, an uncovered stent is considerably cheaper, and at least my personal recommendation is to use an uncovered self-expandable metal stent in that setting. I'm hopeful that with the newer chemotherapeutic agents and use of personalized medicine, such as Precision Promise, that this will expand the pool of patients with pancreatic cancer that can be operated on and ultimately cured.